Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Jr. Family Broadcast Studio here in our hospital. Welcome to Open Mics with Dr. Stites. You can find me here every Wednesday talking about all things COVID, as well as a lot of other topics. And today we have, I think, one of the most important conversations that we've had over the last year and a half. Today we have several really good guests joining to talk with us about the 40th anniversary of the AIDS epidemic. This is especially prescient today because of the differences and the similarities between AIDS and COVID, and I can't think of a better group of people to speak with me about it than the following. In studio with me is Dr. Daniel Henthorne. Dan is a good friend of mine. He's the Director of Infectious Diseases here at the University of Kansas Health System. And Dr. Lisa Clough, who's one of our outstanding infectious disease physicians. And joining us virtually from a conference is Dr. Wissam El-Atrini. This team is amazing, folks. I've worked with them for years. They do a great job here in our health system taking care of our patients. But before we talk with them, I want to share our COVID-19 inpatient numbers from overnight. So here we go. Today, our COVID-19 count includes the following. We have 31 active patients, 11 in the ICU, of those are in the ICU, and 6 on our ventilators. So those are going up. Now, interestingly, we peaked at 38 active a few days ago. Now we're down to 31. You think, well, that's really good news. We do have 25 recovering, so the total account's up to 55. And you look at that graph and you'd say, oh, that's really good. We're down a little bit. But here's the rest of that story. We are full as a hospital. And because we're full, we cannot take transfers. And we have been turning down between 1 and 5 or 6 acute patients every day. And if we had been taking those for the last 2 weeks, we would be pushing 100 acute infections. And just to say, back last fall, we had beds available. Think about that. Why do we have beds available? Why was that? Well, I'll tell you what we weren't seeing last fall. We weren't seeing RSV, we weren't seeing parainfluenza, and we weren't seeing even like rhinovirus coming into the hospital because patients were all masked up and we were socially distancing. And as a result, we had more open beds. Today, the rest of our hospital is running full steam, as we are throughout our region and throughout Kansas City. In one of our calls yesterday around the transfer center, because we haven't been able to take as many patients, one of the things we've learned is that almost every hospital in Kansas City has the same story. Before, when the numbers were down and people were actually not coming to get care when they should, like with heart attacks and strokes, and not getting their cancer follow-up, etc., we had a lot more beds. Today we don't have beds. And so we are turning down transfers, which is creating, I think, a real concern, maybe even a crisis here in our region, because patients are having trouble landing into beds anywhere near their hometown. And as we watch our numbers rise, and we're going to talk about that in just a moment, we're going to see this problem exacerbate. In the meantime, at Hayes, they're up to 6 acute patients. That's another one since yesterday. They don't have anyone intubated. They haven't had, they didn't have any deaths yesterday. So let's talk about this graph for just a moment. This is our hospital inpatient age breakdown. If you've been with us for a while, you look at the graph, what you'll notice is it's younger. Also note, today on the way in, listening to NPR, they were talking with the chief of infectious diseases in one of the hospitals in Miami. She was commenting that they have a lot younger patients now than they did before, and that those people are coming in hot, which means they're really sick, they're going into the ICU, and they're requiring ventilation. The Delta virus, the Delta variant of the coronavirus, is really tough because it's so much more transmissible, and young people are getting so much sicker. And you know, I think one of the challenges to us is, even though our population is a little more vaccinated, the real challenge to us is that we don't have any public masking mandates, and we are not socially distancing. This is a graph, it comes out of the New York Times, I call it the heat map, and it's the risk level. And a number of weeks ago, the risk level was all around Springfield. It was all purple because those are the unvaccinated counties in Missouri where we saw an outbreak. There's also one up north in the St. Joe area. As you can see, though, Missouri has been overrun now by these purple boxes, or the purple counties, which indicates the highest risk level. And the highest risk level is what's your rate of new infection coupled with how well you're vaccinated. And as you look at that map, it's crawled all the way up, and now it's got Jackson County, Missouri. It's got Wyandotte County, Kansas. It's got the whole eastern side of Kansas. It's branching towards Wichita. Johnson County is getting surrounded by this. And what this means is that Delta virus is spreading. More people are getting sick. And this has become now the pandemic of the unvaccinated. This situation could well grow worse if we don't respond, and we have two great ways to respond. One, get vaccinated. Two, follow the rules of infection prevention and control. We know how to do that. The rules work. They travel with you wherever you go. And if we don't do that, that is when trouble is at our doorstep and we become the highest risk areas. Don't wait for a public health official to tell you to mask when you're indoors. Don't wait for a public health official to tell you not to gather in large crowds or go inside for a large group gathering. You need to take the warning now. You need to heed the truth. And the truth is, we're back in trouble again. And right here in Kansas City, we have a third wave. And that's not true throughout the country because a lot of areas are a lot more vaccinated. But the truth is, right here in Kansas City and in Missouri and now on the eastern side of Kansas, we are experiencing a third wave. And that third wave appears to be growing. So let's see for just a moment if we have any reporter questions on the line. And after that, I'm going to turn to my guests. We're going to have a conversation about where we are in the pandemic. And I may pull them in for the reporter questions. But let's see if there are reporter questions so far this morning.
Hey, Dr. Stites, Cody Holyoke with KMBC 9 News.
Hi, Cody.
Hey, let's talk a little bit about this. I know you say you shouldn't wait for public health officials to tell people not to mask indoors, but there's pressure for kind of a reset. I know a number of doctors, as you know, are calling on especially schools to require masking, at least for some students. I know last night, Kansas City, Kansas Public Schools said, you know what, we're doing it for the whole year. Is that recommended? What are you seeing, and what do you suggest?
Well, I'm going to turn to my panel with this question as well, Cody, but my answer is yes. I think people need a mask again. We're in trouble. The numbers are rising. Hospitals are full. We're turning away patients from outside places who need our care, both with COVID and without COVID. And I think I think we're at a tipping point. And if we don't take it seriously, we could easily end up back where we were in November. And just to say, I think from a hospital pressure standpoint, we would have a much higher census if we had another 100 beds that we could use for COVID-19. We would have filled all those beds with our transfers, and we just don't have any beds to put them in. So let me turn first to Dan Henthorne. Dan, you've been in infectious diseases for approximately a very long time. It's great to not be the oldest guy in the room again, just to say, but we're not going to tell everybody how old you are. You always look so darn good. How old you are? What would you say to people? Masking?
I get it that people don't like masking, but with the surge and increase of cases that we're seeing now, it looks like we have to do that again.
Dr. Clough, what thoughts?
I would agree. I think masks are important. And, the narrative that I say in my head is, I'm doing this for you as much as I'm doing this for myself when I'm out and about, and maybe I have a situation where it's not feeling as comfortable as I would like it to be. I truly believe that is important for everyone, that we continue to wear masks.
Dr. Al-Trini.
I agree with my colleagues as well. I'm wearing masks when I'm going to grocery stores now, even though I'm vaccinated. I just think that this variant, as you said, this area is getting increase in numbers. And now the states and local cities will have to take their own measures, even if the CDC, for example, is not going a nationwide recommendation.
And we've seen already that LA County has gone back to a mask mandate. We've heard for last Friday a combination of chief medical officers and public health officials put out a joint statement saying, guys, you need to go back to wearing masks. And I know we were part of that and part of the authoring of that, so clearly believe in that. And now New York City has announced this morning that they're going to require that those who work in the public hospitals, city-run hospitals, there are 11 of those in New York, to either be vaccinated or they have to have a test weekly. So, the truth is what the truth is. And people can listen to the made-up news network and don't do the Munns thing. Rather, listen to what the truth is, and we're telling you the truth. We're back in trouble, and we need to be masked. Other questions? Cody, any follow-up?
I know that Governor Mike Parson is starting an incentive program, and I know you've talked about incentives before, but Dr. Clough talked about this a little bit. There's personal incentives too to wearing a mask, and I don't want to tee up that response, but just your thoughts on that.
You bet. Dr. Clough, you want to talk a little bit more about that, the personal incentivization for wearing a mask?
Well, I think in regards to just mentioning that I think it's important to protect ourselves as well as to protect others in our community. And I think that it's really a measure that we can all embrace and that we can, unify around in order to try to continue to control this wave that we're seeing, which is really, I think, a bit quieter and sneaking up on us more than in ways past.
Dr. Henthorne, thoughts?
That's true. If we're immunized, of course, we think, well, we're protected, but we are getting a small percentage of people who are immunized who do get the virus. Some get sick. Those who don't get sick can shed the virus, even though the virus shedding is about half of what it would be otherwise. Yet that risk is still there. So, yes, we protect ourselves and others if we do that.
You know, I think the mask is really an expression of love, both for the family and the people you care about and your community. And I think we have to think about this not only as individuals, we have to think about it as a community. It affects all of us. Dr. Alatrini, you're used to traveling the world. Your parents are back in Lebanon, and Wissam and I are very good friends. I follow him on Instagram or Facebook, and I'm always nervous when he leaves the country. I'm like, Wissam, where are you going? Can you get back? And I know you've had to make a lot of personal sacrifices over the last year in order to help keep people safe.
Yeah, that's true. I'm actually I'm attending the International AIDS Conference. Was supposed to be in Berlin, Germany. So obviously, with their current situation, they have it virtual. So I'm this time just attending it from here in Kansas City, virtually. But I want to echo what you mentioned about incentives for masking. I want to make the comparison to HIV and prevention and wearing condoms. The problem with measures like masking and wearing condoms is it requires people to change behavior, and that's not always easy, as we've seen. So anything that can help, like being creative and incentivizing people, giving awards or things like that, like some states are doing, or cities participating in lottery for vaccination, for stimulating people to have an incentive. Hopefully that will help.
Yeah, and Cody, just to say, you've heard it right here. Only with our infectious disease colleagues would we say that condoms and masking are similar. But I think actually there is a pretty good analogy here, because both help keep everyone safe. And I think, again, this is a community, and what we have to do is show love of community and of our friends and family. And to do that, we got to keep each other safe. So,
thank you.
Other questions?
Dr. Stites, Brian with KMBC has a couple of questions. Why did the CDC change how it defines breakthrough cases?
Great question. I'm going to turn to Dan Henthorne for that one, because he'll be smarter, or Dr. Clough or Dr. Alatrini. But all three of these folks are smarter than I am. So let's start with Dan. Why did the CDC want to change their definition of a breakthrough case?
I didn't hear that statement. Lisa, did you?
Wissam may have.
Wissam?
I think that refers to changing the definition from just having a positive PCR test from being symptomatic. I guess that's what the question is referring to. And in reality, all of the vaccine studies have looked at a symptomatic COVID-19 disease. So that would make sense that sometimes vaccination would not technically prevent infection, but would definitely prevent symptomatic infection. So that kind of makes public health sense. Is vaccination is trying mostly to prevent symptomatic disease from people getting sick, hospitalized, or dying from the illness, rather than just having an infection, if I'm understanding the question right.
Yeah, and I think that's right. And I think as I look through, just as a point, I think as I look through our cases, we do have some vaccinated patients hospitalized at KU. It represents between 5 and 10% of our case volume right now. In fact, currently, I think there's 3 out of the numbers we have that are positive of the 33. So, but when you look at those patients, a couple of thoughts. First of all, it means that 90% of people are unvaccinated who are hospitalized. Once again, this is now a pandemic of the unvaccinated, right? It's a pandemic of the unvaccinated. If you're vaccinated, you do come in, it's probably because either A, you're really, you didn't respond well to the vaccine, so you're essentially unvaccinated. And the reason you didn't respond well is you're terribly immunosuppressed, like you've had an organ transplant. And so I think that really, if you're, for 99% of the population, vaccination is the answer out of this pandemic. It may require more vaccine booster shots if you're really immunocompromised. We just don't know that yet for sure. So remember, I think the point about the CDC changing the definition is to just bring attention to the fact that, yeah, you may be positive when you've been vaccinated. We always knew that. The reality is you're not going to be hospitalized unless you're someone who probably didn't respond to the vaccine, which is what our population shows, and that if you've been vaccinated, you're darn safe. This is now a pandemic of the unvaccinated. And the problem we have in our area is that in Missouri, 60% of the population is not vaccinated, and in Kansas, 57% of the population is not vaccinated. Those are the folks at risk. Other questions?
Is the CDC trying to lower the number of vaccinated people who show up in the numbers as being sick with COVID?
No, I don't. No, we're confusing data. That's a confusing question, because the reality is this. If you're sick with COVID, then the folks who are vaccinated, as we've just documented in our own population, we've been really transparent about this right from the start, the folks who are coming in the hospital that are vaccinated are people who we don't think responded to the vaccine because they have so much chronic illness. And remember this, some of our patients are so sick that even if they get a mild cold, they can be tipped over. And that's the person who may have heart failure, diabetes, and renal disease and is on dialysis. Someone like that, it takes virtually nothing. A puff of wind can, a salty cheeseburger can tip you over and bring you in the hospital in heart failure. And I use those. Those aren't, I don't mean that as an exaggeration. That's actually a really true statement, right? You guys have all seen it. If somebody has a bag of potato chips, not a bag, one of those little lunch bags, and they'll be in the hospital because they go into heart failure. And you take someone like that and they walk such a narrow tightrope. That's the person who, even if vaccinated, may get sick and have to come in the hospital, but it's because they have such severe underlying chronic disease, it doesn't take much to tip them. Now, the difference is, if they were unvaccinated, then they would also have COVID pneumonia and then they die, and that's a different story. So I think if you're in healthcare, this all is very clear. When you're outside of healthcare, it can get kind of confusing, but it's consistent with the story we've told you all along. Again, I just come back to the list. We have 33 acute infections. 30 have not been vaccinated. 3 were, and the 3 that have been vaccinated are either so chronically ill that even a simple thing like a bag of potato chips could have brought them in, or, and this is an important or they didn't respond to the vaccine well enough in the first place. So, I don't know, Dr. Clough, any further thoughts?
I agree totally. And I think understanding the effectiveness of the vaccine, even amongst people who do acquire COVID, is important to recognize that those symptoms are mild. It decreases the risk for hospitalization and disease, and we need to keep understanding that. And the more that we appreciate the effectiveness of the vaccine, I think the more that we continue to embrace it.
And so again, remember, 90% of the people hospitalized, 91 at KU currently, were unvaccinated, right? Think about the data, think about the odds. Any other reporter questions?
Yeah, another question from Brian. Last question. If people can still get sick, still have to mask, then why get the vaccine?
Yeah, because you're not going to come in the hospital. That's why. I mean, you're not going to die from COVID. It's a very simple, straightforward answer to that. And if we get people vaccinated, then we're safe. And the problem is, because so many people are vaccine hesitant or resistant, then we're not safe as a society. And the reality is that vaccination is safe. Guys, have you seen any really bad outcomes from vaccination?
No.
No.
It's also important to state that people who have had COVID disease don't necessarily have antibodies. And we have seen people who have had the disease, who have checked antibodies, they're not there. We don't know about cellular immunity. They might have cellular immunity, but those people should be vaccinated as well.
Yeah, it's just, we can't get this point across strongly enough.
And there is data showing that people that have had COVID that then get a dose of vaccine have an even more robust immune response as well. And so they really benefit from that additional vaccine.
And that we know that people who have had COVID may be still very susceptible to the Delta variant.
Mm-hmm. Yeah.
One way to look at it is if people are vaccinated, then let's say you're 70 years old, what that does, it moves you back to, say, 50 or 40 in terms of your risk factor. It doesn't make you have all risk factors go away, but in other words, it makes you as if you were younger. But unvaccinated.
So wait, let me get
And
this
who
straight.
doesn't like that?
COVID vaccine makes me younger. Let's be
That's it,
careful with
that's
that
it.
headline, people. We're not quite saying that
It's
yet.
the Botox.
It may not be
we're
that
all
great
waiting for.
yet. Okay. All right. So we got a video we want to show you. We want to kind of get into this conversation about AIDS now, and also the relationship between, because Dan and I lived through this first pandemic. Wisdom's probably too young, and you trained during it.
I was on your coattails, yes.
Yes,
I was.
ma'am.
That's
Yes, ma'am. Okay.
I
So let's see.
remember.
Let's roll the video.
The lifestyle of some male homosexuals has triggered an epidemic of a rare form of cancer.
Ryan White says he gets very lonely. He misses his friends. The 13-year-old was banned from school after it was found he was suffering from AIDS.
AZT was tried as a means to prevent the virus from reproducing itself in the body's healthy cells. And it worked.
He died today of a respiratory illness related to the disease.
The quilt would cover more than 1.3 million square feet.
You know, I just have to say that video of Ryan White and the diagnosis, man, that just takes me back. Because I was there, and I was I was a medical student in 1985, and I remember I was on a neurology rotation. And we had, a gay man in one of our in the hospital, and he had some neurologic symptoms that we later understood to be transverse myelitis from HIV disease. But at the time, we didn't know what the heck we were doing and what was going on. And I just look it back and I shudder and I think, you know, I remember the story and the band played on. Everybody just kept acting like nothing was going on because they thought it was in a gay population. And I look back at that, and it just is such a sad, horrific time. And I don't, as we live in this pandemic, I'm not sure we remember how bad the pandemic was back then, Dan.
You're right. You're right. In fact, we would fill up almost one whole floor, one whole ward with people who just had wasting disease with HIV, Kaposi sarcoma, PJP pneumonia, and other disorders, and it was horrible.
And I remember that when they were the death rate was 80%.
Oh.
It was because we had no
everybody
treatment.
died.
Yeah, everybody died.
Yes.
And Lisa, you were a trainee then and a medical student, and you've lived through a lot of that. What are your recollections of HIV time?
I agree. I think it was just a period of unknown, of fear. We were trying to gather as much information and understand who was at risk, what were the factors that we could control and not control. There seemed to be so much uncontrolled during that period of time, and as Dan mentioned, just the sorrow associated with watching people, suffer and succumb to that illness just was really difficult.
Wisdom, you're at an important meeting around this topic today. How's the mood in that meeting? How does it feel?
Well, obviously, things have changed since the 80s and the 90s with HIV treatment. There have been a lot of progress. I know you're going to ask subsequent questions about that, but there's a lot of optimism in the HIV field. There's an active research program for HIV cure. We know that now people who are diagnosed with HIV and who get started on therapy very early, and there are so many medications available nowadays, they can expect a normal life expectancy. So things have drastically changed, and the mood at the meeting is mostly about some loss in the gains in the public health advancement in HIV due to the COVID pandemic. Now HIV is pretty much competing with other healthcare priorities, mainly COVID since 2020. So a lot of funding and research priorities have kind of switched. Everybody kind of stopped what they're doing and started researching COVID, including people who were researching HIV cure and advancement.
Yeah.
So why do we not have a vaccine for HIV, Dan?
That's been very difficult to come up with. We've had great researchers really working on it, but this virus just keeps changing and mutating, and has been very difficult to build an antibody that would work well. So I know even here at KU we had a researcher who was studying that and came very close to developing one. It would work in simians, but it never was in humans. So it's been, but the other thing, the competing factor is that we now have one pill once a day that changes the life expectancy so that it's not any shorter than it would be normally. It's much better disease to have, for example, than having heart disease or diabetes or cancer or whatever. The life expectancy is at least as long as people who don't have it with one pill a day. So because of that, there probably is a little bit less urgency to the push, but it's still being worked on, as Dr. Wissam just said.
Yeah, and I think that's a really important point, because therapy has brought us a long way, Lisa, and yet still a lot of people out there are suffering from it. And just to say, as we had to learn then, this is not just a disease amongst gay men or a disease amongst people who use drugs. It's also a disease of heterosexuals. It was a disease at that time that was found its way into the blood supply, and so even people who just were receiving blood for a C-section, for example, were getting HIV.
Yeah. And I think there is a bit of our human nature. We've done that with COVID, where we want to identify risk groups and then tell ourselves that we're not in that group, and that sort of helps us to kind of get along. And I think the history of HIV has been that way as well. Is that we want to say, oh, that's that group that's getting this infection, or that group. But the reality is throughout time that those groups are becoming larger and overlapping, and that all people that engage in activities that put them at risk are at risk of getting HIV. And so prevention continues to be at the forefront of really the control of the epidemic, as we're talking about in COVID. We would rather be talking about prevention and vaccination than we would necessarily be focusing just totally on treatment. Treatment is so important and impressive, and we've made such great strides. We have still room to go in many ways, and I'm excited about the therapies and the new ways that we're delivering medications, but I still do have a heart for prevention. I think that's just so important.
Yeah. What we can do is so much better than what we've done, and I think as you guys look at the AIDS epidemic, having lived through that, or AIDS pandemic, it really was a worldwide crisis. This is really our second pandemic, Dan, right? I mean, this is our second one we've been involved with in our careers. I remember being just so, and it affected, the AIDS pandemic affected me personally, because I had several family members die from AIDS, and I watched physicians refuse to give care to them. One of them had a heart attack, was taken to a local hospital. They refused to take care of him because he had AIDS, and ended up coming here. But you look at that, and it just hurts your heart. And you think of the lives and that were wasted. And if we had just had effective vaccination then, it would have made such a difference in so many lives.
Yeah. It would have. It would have. In fact, people were excluded from medical school, from nursing schools, from various places. There were physicians who were resigning, retiring because they were afraid of it. One prominent physician in California was an orthopedic surgeon who quit because of it. So those kinds of things were commonplace because there was a lot of misunderstanding, didn't understand what was going on, and they're afraid for themselves. And colloquially, there were the 4 H's that we talked about of people who got it. We talked about the hemophiliacs, we talked about the homosexuals, we talked about Haitians, we talked about heroin abusers or IV drug abusers, and they were used as pejorative terms, but because it was other people too who were getting it, but that was sort of the colloquial discussion about it at the time.
Yeah, we sort of villainized it, didn't we?
We did.
And we turn AIDS patients into villains, and I think we have to be careful about not turning in those who are unvaccinated into villains, because I really think the unvaccinated are the victims right now. Thoughts about that, Dr. Elatrini? Are we going to turn the unvaccinated into villains in the United States in COVID?
Yeah, we have to be careful about not be judgmental with public health advice. HIV has suffered with the stigma and discrimination to people infected, and that was part of the reason why initially there wasn't a lot of attention to it or funding, because the thought was it's affecting only a small fraction of the population, even though now we know that globally about half of the infections are heterosexual transmission. Still in the Western Europe and North America, the majority of infections are among men who have sex with men, but still about a quarter of infections are among heterosexuals. 10% of new infections are among women in the U.S. So we should not classify people, we should not judge people, and just offer treatment and prevention when they're available.
And I think our role is that of encouragement. Again, we don't want to judge the unvaccinated here for the COVID crisis. Rather, we just got to point out how at risk you are, Lisa, because, I mean, this is I think, a clear problem. Dr. Clough, thoughts about that?
Yeah, I think that we need to think of ourselves as unified and together, that we really, COVID is just a compressed sort of representation of what the issues of HIV have borne out slower and over the years. I mean, starting with the fear and the uncertainty and the lack of knowledge, but then as we gained and grew in that area, we've become more comfortable. Many providers were very concerned about taking care of COVID patients at the beginning of the pandemic, and I know now we still have caution and concern, but we've learned more about the risk of transmission and how to prevent and care for ourselves, and those things have helped us to become more comfortable with that. And so I think that has allowed us to sort of enter into a more empathetic period of care. And I think, whether we're talking about people wanting or not wanting to be vaccinated or the care that they receive, we need to have empathy from where they come from, what their thought processes are. We need to help continue to educate that. And as we, as providers and individuals in healthcare, can sort of meet people where they are and help us all to bring ourselves along so that we can grow and, address the issues at hand, that's where the progress makes. And that's what's happened in HIV care, but at a much slower rate over many decades, really. But there's a lot of similarity and parallels in that regard.
Yeah, I think that's brilliantly said. So AIDS is something we've learned from. What are some of the public health measures we learned from HIV that we're trying to apply to COVID? Thoughts about that? I'll say that to the panel, and Dr. Henthorne, I'll start with you. Did we learn anything?
Well, we don't learn very well from history. I think back about Dr. Robert Hudson's article that he wrote in 1978, talking about how that when pandemics occur, the population responds just exactly the way that they responded to the plague in the 1500s, and how that when Legionnaires came along, when HIV came along, with each of these, people have so much fear, and they run from it, they try to hide, try to get away from it, without thinking about it rationally. So it was a very interesting concept. But we think the same way that the ancients did. We don't think differently.
Yeah. Dr. Clough, thoughts?
Yeah, I think that we just need to continue to understand that this works in phases, and that we continue to gain knowledge. We can have better interventions when we can, really share those experiences that we had in HIV and in the current pandemic. And then that actually helps us to look back at HIV and how we address that and the progress that we've been made. I think the COVID pandemic is really going to encourage continued work and support in the HIV arena as well. They overlap in many ways. So.
Dr. Elatrini.
Yeah, to make the parallel and of what the world has learned from HIV and how that benefited COVID response. First of all, the importance of non-pharmacologic intervention, wearing masks, distancing, things like that are similar in the HIV side as wearing condoms, and how these are important early on when there's no drugs, when there's no vaccines, and still important, I guess, when a good fraction of the population is not vaccinated. And then all the research into vaccination that has been going on for 2 decades now, trying to come up with an HIV vaccine, has all these platform technologies were present already and were used to quickly develop a COVID vaccine. Unfortunately, they were not successful in getting an HIV vaccine on the market, but pretty much the COVID vaccine response did not invent a new technology. They just use platforms that are already present that are being used for other diseases.
Yeah. So important things. Well, Jessica, I bet there's a few questions out there,
Yeah,
so
there
maybe
are
we should take
yes,
them.
a lot of COVID questions, but a couple on topic today. But Georgianne, one of our faithful viewers, good morning to you. She says she does remember the AIDS epidemic so well. She remembers it being in the news every single day. In fact, lost some really good friends back in 1991. But a question is just for the entire panel is socially, how have you watched the stigma change and the pendulum swing from back when doctors didn't even want to care for people out in the streets didn't want their kids going to school with the Ryan Whites or touching hands, to now where we have celebrities coming forward and people just living with it? I just would love to hear from the panel about that.
All right, Dr. Alatruni, your thoughts first.
Yeah, there has been a lot of progress, but not enough as far as addressing stigma. Still at the conference this week, there's a lot of sessions about addressing stigma worldwide. You can think about the risk group for HIV in a lot of parts of the world outside sub-Saharan Africa are still men who have sex with men, IV drug users, sex workers, and their customers. So there is still a lot of barrier for these groups to access healthcare and for funders, researchers, politicians to agree to support them and to kind of try to reach them, to test them, to get diagnosed, to get on treatment, to be linked to care, to stay in care. So there's still a lot, even though the public health view have changed, but in reality, in a lot of places, stigma persists.
Yeah, Dr. Clough.
And I think, it's reflective of the risks associated with acquiring infection. And anytime that you're dealing with a contagious issue, it then tends to focus on behaviors, and behaviors can define groups. And then again, we want to separate ourselves and say, I'm not in that group, I'm not part of that. That's a risk behavior that someone is choosing to take, and we can do the same thing in COVID. And I think that we need to understand that that's not a productive approach to have, that we need to put the behaviors, although they're important to target in regards to controlling the infection and the contagiousness, they don't define the person, and we need to move beyond that. That's one of the things that I always try to share when I'm in my clinic is that this is not who you are. This is something that you have, and part of the process of helping someone work through a new diagnosis into treatment and to a life that becomes more stable is for them to be able to see the goodness that they had inside of them that was maybe not apparent to them, but that is still there, and to be able to see that. So I think really helping people not to define by behaviors, but define by our own, humanness and what we can do for each other in our society is really important to me.
And can I just say, beautifully said. And so I can see why you keep her around. But also that's so much true about those, because I think it's very easy to villainize those who are unvaccinated and in the same way. And what you really just have to say is, look, guys, we all bring good to the world, and we can't bring that good, we can't help others if we don't take care of ourselves and therefore take care of our community.
That's right.
And I think that's really important.
That's right. And the hope is that on the other side of this pandemic, that we will have learned and been able to hear things about ourselves that we maybe didn't recognize, and that we can always, we can change ourselves and we can try to improve. I always say I'm, becoming the better version of and the best version of what I was intended to be. And I think these pandemics, whether HIV or COVID, press us to really ask those important questions while we're solving the science and progressing the science and helping people to both prevent and treat HIV. But there's another story going on as well. So
the rules of infection control keep you safe, and they say I love you.
There you go.
So, COVID question. Judy wants to know, do the doctors think vaccinated people who get breakthrough infections should have their immune function investigated?
What do you think, Dr. Henthorne?
That's going to be difficult. You can certainly get antibodies to fairly easily. To get your immune system investigated is more difficult. So usually most people do not. What you do is a general screening test to make sure that they don't have a neoplasm cancer, some obvious underlying conditions, diabetes. Those things should be done, but those will be done by the routine studies. To say we need to do spatial lymphocyte investigation is more difficult and is not routinely done.
So I want to break that question up into two parts. If you've been vaccinated and you then test positive for COVID-19, and by the way, we've had 59 of our employees be in that position, but they're not sick, that's to be expected. Because vaccination does not eliminate the chance of contracting COVID-19. It markedly reduces your chances of hospitalization and death. That's why you get vaccinated. And we also know there's another benefit from it that we didn't know originally, which is your likelihood of transmitting it to someone else drops dramatically, yes. And your likelihood, in fact, of you actually getting it drops dramatically, but you can still do it. So that's why they're changing the definition of breakthrough infection, because you see, that's really not a breakthrough infection. That is an expected outcome. Breakthrough infections are, in my mind at least, are the ones who come into the hospital. And that's why we talk about it. We've been honest about it every day. And we've said vaccination is not a get-out-of-jail-free card. It is a card that says you'll be much safer, you'll take care of yourself, and you'll protect the others in your community. And if we can all get vaccinated, we can go out and do the things we love to do. Can you still come in the hospital if you've been vaccinated? Yes, but the circumstances are different. You have to have severe chronic illness that's going to be tipped over, and that's why you're going to come in the hospital. And there's an important difference there, Dr. Clough, I think, and I'm not sure people understand it.
No, I agree with you, and I think that we need to start thinking in our minds of those individuals that have been fully vaccinated and do acquire infection. That's vaccine effectiveness. That's not vaccine failure.
Right, because they're not in the hospital.
That's right. That's right.
Dr. Alatrini, how do you talk to patients about getting vaccinated? What do you say to the vaccine hesitant?
That's another thing we've learned probably from from dealing with HIV denialism, if you want. Interestingly, with every pandemic, there's this wave of misinformation, conspiracy theories that people tend to believe. And I've had patients with HIV, I'm kind of changing here to back to HIV, that don't believe the virus even exists, and that this is all a conspiracy theory, that pharma companies want to benefit from drugs and things like that. So you should just be consistent, be clear with the medical advice managing, at the same time be empathetic and trying to understand where is this coming from, what are the fears, where are they getting their information from, direct them to sources of information that are reliable, and hopefully change their mind.
Yeah, well, that's just done. Please.
Oh, I was going to say, each person has their own idea of why vaccination is a good or not good thing, and how understanding where they are coming from specifically and what their questions that they have, and sort of starting the conversation of where they are, and helping them to move forward from that, I think is so important. We can't just assume everybody has the same reason in opposition of vaccination. It's not a helpful stance to have.
All right, so Stacy and Kimberly and several others asking questions about children and vaccines. And so Dr. Pahoud from Children's Mercy is going to join us tomorrow. So I'm going to save your questions for that. Catherine asked, did I understand the doctors to say that one of the reasons there is no effective vaccine for HIV is because it continues to mutate? If so, don't you think that's a strong lesson to apply to COVID? Unvaccinated are the breeding ground for mutation?
Wow, that's a listener who's listening, folks.
Yes.
Well done. Yes, that is.
Yes, that's very good.
Yes, the answer to your question is yes. And we can go on about it. Please.
Wissam may have more information about this, but I think it's a good point, is this that in many ways COVID and HIV are similar and in ways that they're different. And that's when, going back to Dr. Stites' question as to why we don't have an HIV vaccine. Mutation and replication amongst HIV virus is much more robust and profound, and that makes it more difficult for the development. And so I think, yes, controlling virus is key to preventing mutations and resistance, and is really the crux, one of the crux of the matter. So.
Wissam?
Yes, I want to add, back to the differences between COVID and HIV. HIV is a retrovirus that integrates into the genome, as opposed to coronaviruses, which are an acute infection that resolves, and when patient recovers, there's no more virus in the body. With HIV, you have a virus that integrates into your own genome and establishes a lifelong infection. That's one difference. Second, HIV is very, very hyper-mutating virus. It does not have any proofreading with the transcription of its DNA, and the immune response to HIV is weak. The virus infects the very cells that are supposed to mount an immune response, so the immune response to HIV is very ineffective. Only a fraction of patients with HIV develop what we call broadly neutralizing antibodies, and this happens after several years of infection. With coronaviruses, you get an acute infection that resolves, and the immune response to coronaviruses is very good. Most people develop high-level neutralizing antibodies within a couple of weeks of infection or vaccination. And the genome of coronavirus is relatively stable. Even with the variants that we're seeing, this is just a minor fluctuation of the surface spike protein, which is nothing to compare to the changes that happen to the equivalent protein in HIV. So these are the major reasons. HIV vaccine research has stumbled for years. This year, actually, there was yet another failed HIV vaccine trial published in New England Journal. The trial that was going on in South Africa since 2016 was just stopped for futility. And now research is moving to developing this broadly neutralizing antibody for HIV, either for prevention or for treatment as injections like every 2 to 4 months. So the field has moved a little bit with HIV vaccination to trying to get a vaccine that elicits those magic broadly neutralizing antibodies.
Kind of like the magic we've seen with the vaccines we have for COVID. And just think about that. You've had to get 2 shots about a month apart, or 1 shot with J&J. And now you're talking about having to get a vaccine every 2 to 4 months if you want to develop neutralizing antibodies to HIV. Wow. There's a little bit of difference there.
Time for just a couple more?
Let's do it.
Okay. Well, I'm just going to read Ross's statement just to show kind of how I think frustrated some people are. He says, again, why do you think we should have ditched the mask in the first place? My God, is anyone out there playing with a full deck? So I think...
Well, that's a good question.
It's a question, good statement.
I don't have a full deck on most days.
But you still wear a mask. But you're still playing it safe, right?
I'm still playing, just a little shorthanded here.
Right.
But I just think that to answer that part, I think, it's hard, right? Because what you're trying to do is balance the need of our society and to get together, and especially around students and things of that nature, to be able to gather together and do things, and to keep the economy going. And so when we ditched the masks, as you said, the problem was we did it in favor of the economy. And it was with a bit of a bet on the come, and the bet on the come was that people would get vaccinated. what we're seeing in regions that are unvaccinated is they still didn't get vaccinated, and now we're reaping the benefit of that decision. And unfortunately, what we are reaping is more COVID. And so I think it comes down to whether or not a simple public health measure can be effective. It cannot be effective when it sits in a syringe. It can only be effective when it's in your arm. And then we can take the mask off, I think, more safely.
Yeah.
So we're data-driven. As the data changes, then we make changes in our recommendations. And the data involves not only the epidemic, the pandemic itself, and the patients who are sick, and the numbers, but also involves the economy and other factors, too, looking at teenage suicides and alcoholism and drug use and all these other things are factors that we have to consider in all this.
So we saw a huge spike in the amount of drug use, a huge spike in the amount of teenage depression, a huge spike in the number of suicides. So again, those are all public health issues that we had to address. And so removing masks made sense.
Balance.
When we had 2 patients. Remember, in March, we were down to 2 patients in the hospital.
Yes.
And we were like, this is the best. We get people vaccinated, we're done.
Right.
The problem is we didn't get people vaccinated, and then the Delta variant arrived. And the Delta variant's more transmissible. And so we had all these people gathering indoors with a variant that is much more transmissible. And so now this is where we are. And the answer is, Dr. Clough, you got to be vaccinated.
You do. Mm-hmm.
Okay.
All right, so just clear a couple of things up really quick. So Brenda says the people that are vaccinated and in the hospital, are they on a ventilator? How bad are the people in the hospital doing?
Yeah, there's 3 of them, and they are still very sick. And I'm going to try and say one of them is in the ICU, and the others are on. I'm just looking at where they are in the hospital. The others are on the floor.
But is there
So
anyone
1 and 2.
vaccinated on a ventilator?
We did have somebody early on, but there was one person who was getting active chemotherapy and had CAR T therapy, and we had one person who had a kidney transplant. So those are 2 people you think really never responded to the vaccine, right? And that's why that's why the discussion's out there. Who, if anyone, and I think we're going to end up seeing that there are some subpopulations, who will need a 3rd vaccination?
All right, just last quick question. Mary says, do you think fully vaccinated people getting together inside unmasked is okay right now?
Dr. Alatrini, what do you think?
Well, it's all a measure of risk. If you know that everybody's vaccinated and it's a small group of people indoor, I still think it's safe not to wear a mask. If you're in a grocery shop and you don't know who's vaccinated and who's not, I would recommend wearing a mask.
Agreed? Panel?
Yeah, and I think, that's a question that we have to ask ourselves each week because the story changes. And we need to just be aware of who we're meeting with, what risks they're taking, and our level of comfort with that. So.
And part of that will be proximity of how close we are to the people. If we're distancing, even without masking, if we're 6 feet away and talking to people in the same room, we have a lower risk.
All right. Hey, tomorrow I will be back on the Morning Medical Update with Jess. We'll be talking about something a lot of you have been asking us about, back-to-school vaccinations, including COVID-19. Now, I know we're running a little bit out of time, but final thoughts from our guests. First, Dr. Dan Henthorne.
Well, I'm thinking we talked around about the topic we haven't mentioned really is we have the ability to measure virus in the blood, in HIV, in COVID, and we have it because of a person who was at KU years ago, 1973, 1977, who won the Nobel Prize for his test, the PCR test, Kerry Mullis. And Kerry Mullis was here at KU. He worked in the lab of Leone Mattioli, peds cardiology. And it's because of that test that we can do all the quick tests for HIV, for COVID, and for other viruses that we have and show differences. So shout out to Kerry Mullis.
Yeah,
he's no longer living.
Rock Chalk Jayhawk. Okay. Dr. Lisa Clough.
And on those coattails, I would say, I think understanding where we've come from and having knowledge of where we want to be and what we need to do in between is so important. And both HIV and COVID have shown us that. And so we just need to keep working.
Dr. Wissam Alatrini, final thoughts.
I want to reach out to all patients with HIV or those who are at risk of acquiring HIV to get tested. We know that about 13% of people living with HIV in the U.S. are still not diagnosed. So everybody who can be at risk, or everybody who is between the age of 13 and 65 who has not had an HIV test, to ask for one, because there's very effective therapy nowadays for HIV, and that we know now when somebody is on treatment and suppressed does not transmit HIV for others. So treatment for HIV is actually prevention. So that's a big deal that led to WHO to recommend now treatment for all patients with HIV.
Yeah, thank you very much for that important reminder. Great point. And I love this conversation. Jill, you're listening. I want them back soon. This is the perfect mixture. I just hit a couple of words really quick that we heard about earlier today. Denialism, fear, disease, risk, isolation, that associated with not getting vaccinated, are not wearing condoms, are not taking care of yourself, are not doing the public health measures. When you do, empathy, connection, love, community, normal. Which side of those words do you want to be on? We'll be back tomorrow. We'll see you then.